All right. Before we get started on the third and final lecture of the morning, I just want to hit a couple of points that I may not have been clear enough on. When you order an MRI of the brain, all of these sequences are obtained during that scan. So if a patient is in the scanner for half an hour, within that half an hour, they're getting that T1, T2, gradient echo, flare, DWI, ADC maps. That's all being done at the same time. They don't get a T1, you don't even have to order get T1, get a T2, and add an ADC map. It's all done at the same time, or during one setting. T1s are obtained, then flares are obtained. Patient doesn't move, they stay in that gantry. Diffusion-weighted flare, let me go back to flare. Flare stands for fluid attenuated inversion recovery. It is a very sensitive sequence, but not very specific. As I was explaining to one of your classmates, flare is kind of like the SED rate, the ESR, of imaging. So the SED rate determines an area of inflammation in your body, but doesn't necessarily tell you where the inflammation is. Flare is the same way with imaging. So in that one case that I showed you in the first lecture, of all those blotchy areas of bright signal, it showed all that microvascular ischemic stuff, wasn't really sure what it meant, but when we pulled up the diffusion-weighted imaging sequence, that showed that one that was kind of light bulb bright, which was abnormal on flare, but it was the only one that was bright on diffusion-weighted imaging. That told us that that abnormality was acute ischemia, because diffusion-weighted imaging demonstrates areas of acute to early subacute ischemia. There's another point that I don't think I made that I want to make sure is very clear to you guys. If you see a lesion on diffusion-weighted imaging that is bright, there is another sequence, I may show it on this next image, but I want to make on this next lecture. There's another sequence that is obtained at the same time that DWI, or diffusion-weighted imaging, images are produced. Those are called ADC maps, apparent diffusion coefficient maps. There are many things that can be bright on diffusion-weighted imaging. There are areas of chronic ischemia that might be bright on diffusion-weighted imaging. Well, then what's the use of DWI if I don't know if it's acute or chronic? On a paired set of images called ADC maps, where you read DWI or diffusion-weighted imaging side by side with ADC maps, if you see an area that is bright on DWI, next to that area is dark on the ADC maps, then it is a positive for an acute to early subacute ischemia. It must be bright on diffusion and dark on ADC maps. If it is bright on DWI and bright on ADC maps, it is something we call T2 shine through. It does not represent acute to early subacute ischemia. Dark on ADC map, ADC, D for diffusion, I'm sorry, apparent diffusion coefficient, ADC, dark, diffusion, bright, acute to early subacute ischemia. Is that clear? I'll repeat it as many times as I have to make that clear. It is so important. You weren't here for it. Bright on diffusion, must be dark on ADC maps to be considered acute to early subacute ischemia. ADC maps are produced at the same time that diffusion-weighted images are, and they must be read together. You cannot read them independent. Yes?
And if they're both bright, what did you say?
It's something called T2 shine through. T2 shine, like the sun shines through. T2 shine through. And it's another lesion, it's just not acute to early subacute ischemia. Okay? So we talked about flare. It's sensitive but not very specific. It's the ESR of radiology. It detects abnormalities, but it may not tell you exactly what it is. And we just talked about the importance of reading diffusion-weighted imaging, DWI, alongside of ADC maps to determine whether or not there is acute to early subacute ischemia. Is that 100% clear to 100% of you? Yes? Raise your hand if you want me to repeat it. There's no shame in not understanding. Okay. So when we do an MRI, we get a series of sequences all at once. T1, T2, flare, DWI, and ADC maps, along with gradient echo. If we suspect somebody has acute ischemia, we look at flare. We look at all the images, but I look at flare first. I then go to the diffusion-weighted imaging images. If there's nothing bright showing up on diffusion-weighted imaging, there is no acute to early subacute ischemia. I'm that confident. If there is something bright on the DWI, also known as diffusion-weighted imaging images, I immediately go to the ADC maps, and I find that lesion that is so bright. If it is dark on ADC maps, D is in diffusion, ADC maps, that's acute to early subacute ischemia. Got it? Amy, you with me?
I'm with you.
Okay. Is it clear? Then it's not acute. Oh, okay. Then it's not acute to early subacute. Maybe it is early chronic. I want to keep it at a certain level, though. I don't want to go off and start, because you have an area where ADC maps start to normalize, and it can be totally normal on its way back to recovery. So it could indicate ischemia, but I don't want to confuse anybody here. That's for me to worry about, not quite for you guys to. Is that clear for everybody? I feel like I'm going to a congregation for anybody who's mourning an illness, or you want to call out a name for healing? All right, so we're good? It's funny, everyone knows what I'm talking about. I love it. All right, so any questions about vascular diseases of the brain? I think we're going to wrap up. I'm kidding, Bernice. You ready? This is going to be a quick one. So this is divided, I have this divided up into 2 lectures, vascular diseases 1 and vascular diseases 2. We have time for one, so I wanted to show you the lecture of the diseases that you're going to see most commonly. Ischemic cerebrovascular disease and hemorrhagic conditions. In the ischemic cerebrovascular diseases, that talk about those diseases that cause stroke, our job is to make the definitive diagnosis, as well as assessing for brain that is salvageable. You can have a stroke, and you can still have parts of the brain that are recoverable. It is our job to determine whether or not they're a salvageable brain. If someone comes in and they are totally stroked out, why would you give somebody TPA if that brain is unrecoverable? You wouldn't. Assess for non-ischemic cause such as tumor, intraparenchymal hemorrhage, and subarachnoid hemorrhage. That's why you're ordering the images, right? That's what you want me to be able to tell you. And you also want me to help you exclude any hemorrhagic component. You would not give TPA to a patient that is having a hemorrhagic stroke or has a hemorrhagic metastasis, for instance, right? So a patient comes in, you suspect, or clinically they have a stroke, what study are you going to order? Amy?
You're going to order a CT.
A CT, that's right. And Amy's from Florida. I'm just joking. All right, order a CT. These are the things I'm looking for. We're building. We've seen the forest. Now we're going to start to look at some of the trees. All right, now it gets really good. Just wait until I have you next year. All right, now it's going to get good. We get a non-enhanced CT. This is the most efficient assessment to evaluate for ischemia within the first 24 hours. Now, what do I mean by that? Well, it's like I said before. You can go to any hospital in the Philadelphia area and have a CT 24 hours a day. I didn't say it's the most sensitive, and I didn't say it's got the most information. It's the most efficient. You can get it done, and you can get it done inexpensively. They're available everywhere. Now, as the statistic says, they're usually inconclusive for the first 6 hours. They offer only 58% sensitivity, which is unfortunate because this is the stage where TPA has its greatest effect, right? Now, there's a caveat to this. As multi-slice CT has come on the market, and as imaging workstations have become more prevalent and better, the sensitivity is increasing. We get thinner slices, okay? But for non-contrast, sensitivity is still fairly low within the first 6 hours. Enter MRI, which you can now get at a lot of places, also 24 hours a day. When I was training, we had to call an MRI. I'm sorry, when I was training at Bryn Mawr, there was no MRI after 5 o'clock at night. You needed an MRI, you had to go to a university hospital. Now they're scanning 24/7. In my fellowship, we had to call an MRI tech to come in the middle of the night if you needed a scan, an MR. Now, 24/7. 24/7. Anyway, so a patient comes in, it's inconclusive, they're going to go right for the MRI. I practice at a hospital in Sacramento. They're doing, on every stroke protocols, they're doing a perfusion scan. They want to know right there and then, is this patient having a stroke? And I say to them, I go, you tell me if they're having a stroke. I can't tell you if they're having a stroke. I can tell you if they have ischemia. They hate when I say that. But that's what I'm looking for. I can't tell. They could be having a stroke without ischemia, right? Maybe they're having a seizure. I don't know. Anyway, this is an important slide. This is 5 hours after the patient started experiencing some symptoms. I have not shown you this case. This is, again, one of my favorite cases. All right, Michelle, take it away. Is there a Michelle in the class? Every year there's either a Jen, Debbie, or Michelle. Is there a Jen here? Is there a Debbie? All right, I'm going to go with some new names that I experienced yesterday. Caitlin? Really? Kathy? Are you kidding me? Really? All right, Adam. I know there's a Bernice here. But I've already called on you. I know there's some Megans. Is there a Brittany? What is happening with our parents' names these days? What's your name up there?
Me?
Yes.
Alexa.
I have to change my... All right. Are you feeling good? I know I picked on you before.
Yes, I'm fine.
Okay. This patient is 5 hours after they started experiencing their symptoms. You get to ask me one question, if you want.
What were their symptoms?
Left-sided weakness.
Was something on the
That was the perfect question. What's that?
was something in the right hemisphere?
Well, you tell me.
That's what I'm assuming.
Okay. Without even looking at the images, that's what you're...
If they have left-sided weakness.
Good. Okay. All right, take it away. Alexa, take it away. Alexa, give me the diagnosis. How do you like that? Okay. Alexa, this patient is dying. Okay. You want me to guide you? Is the ventricular system normal? Is there any shift to the midline or mass effect?
No.
Are there any extra-axial fluid collections?
No.
Okay. Great. Now, what did we talk about before in areas of acute ischemia in terms of edema and blurring of the gray-white matter junction?
On the first image on the right, there's a little bit more. Like right there.
Yes, you're exactly right. So see this little white line here? This little bright density? Let's follow it. Where does it go? Kind of ends right there, right? Let's compare it to the other side. Wow, kind of wraps all the way around. Doesn't it? You can follow it here, kind of follow it in, looks like Lake Tahoe, and then you kind of just follow it forward and around, right? That's the cortical ribbon on the left. What happened to the cortical ribbon on the right? It's effaced. That, Alexa, is the cortical ribbon sign. I showed you the MCA sign. This is the cortical ribbon sign. The cortical ribbon sign is the result of loss of gray-white matter differentiation when you have edema or tissue injury in the area. Everyone got that? You've seen the MCA sign, when the MCI was chock full of dense thrombus, resulting in a large territorial infarction. And now you've seen the cortical ribbon sign at work, also indicative of acute ischemia. The MCA sign is the actual thrombus. The cortical ribbon sign is the result of the ischemia, resulting in edema and loss of gray-white matter differentiation. Now, we're going to take it a step further. What vessel supplies the right temporal lobe? Anybody? The middle cerebral artery, correct. What important gray matter structures are supplied by small perforating vessels that come off of the A1 and M1 segments of the anterior and middle cerebral arteries? Basal ganglia. Let's take a look at the basal ganglia. I really need you guys to be very, very careful and deliberate now when you're looking at the basal ganglia, because this was a stroke that was picked up within 6 hours looking at these signs that I'm sharing with you. We're going to start on the left. What is this big structure here? Putamen. What's this structure here? Caudate. Look how distinct this is. And I'm sorry, I can't go around the margins very well, but it looks like like a sail, an inverted sail. Where is it here? It's effaced. Alexa, did you notice that when we put this up? Yeah. Did anybody notice that when we put it up? Why? Because you didn't know where to look. Well, guess what? Now, you know where to look. So, the basal ganglia has been affected. Why aren't the thalami affected? Why isn't that right thalamus affected? I can't hear you.
It's supplied by something else.
What's it supplied by? The posterior cerebral artery. Board's question. The thalami are posteriorly supplied. They're also not part of the basal ganglia. But they are supplied by thalamoperforators that might come off the tip of the basilar artery or just proximal to the tip of the basilar artery, and I should say, the P1 segment of the PCA bilaterally. Thalamoperforators. Lenticulostriate supply the basal ganglia. So, you ready for this one? Alexa, I've been beating up on you a lot. I need to go to a guy that can take a beating. Guy with a red lid cup. What's your name? Tim. Tim? You from the area? No. Where are you from? Like Sharon, Lexington? Never heard of it. Welcome to Philly. Sorry about the Patriots last year. This year, did not count as a Super Bowl. All right. You feeling fairly confident? Okay. Knowing what we just discussed in terms of where the branches of the lenticulostriates come off, where is the thrombus? Is it proximal to the takeoff of the MCA or distal? How distal?
Very distal. It's not affecting patient had weakness in the limbs.
Mm-hmm.
So then maybe more proximal then, because it's affecting both the limbs and then also the
Hmm. So if the lenticular striates come off branches mostly of the M1 MCA, is the thrombus proximal or distal to that? You want to phone a friend? Okay, who do you want to phone? Mark. Where are you from?
New York.
Whereabouts? Upper East Side, Lower West Side?
Lower East Side.
Like Katz's Deli, Lower East Side?
Around there, yeah.
Wow. Do you bring a corned beef sandwich for me? All right. Where's the thrombus? It's got to be proximal. If you're depriving the lenticular striates of blood, it's got to be proximal. So if I draw a graphic here, will you guys be able to see it? I guess this is more visible over here. This is a really crude drawing, but I think you guys will get the point. ICA, MCA, PCOM. I love that. I'm missing the A1 segment here, by the way. A1 segment is down here. Lenticular striate branches. If you knock out the caudate nucleus, thrombus is right here. If you knock out the temporal lobe and parts of the frontal lobe and the basal ganglia are spared, this is very crude, but I just want you to get the idea. This is where the thrombus is. Sure. These are the lenticular striate branches, which in my experience mostly come off of proximal aspect of the MCA. Is that what they're still learning? Okay. I want to make sure I'm not overstepping or that you're comfortable with that. If you knock out the basal ganglia, in other words, if you see ischemic changes in the basal ganglia, blood is not getting to the basal ganglia. If you have to guess where the thrombus is, and it's purely academic, the thrombus must be proximal to, or the very high-grade stenosis must be proximal to the takeoff of the lenticular striates. If you have ischemia in the right middle or the middle cerebral artery territory elsewhere, but you have spared the basal ganglia, and then these are intact. Thrombus is going to be right there. That's a good. Does that demonstrate that? That's an important point. And the thalamus is spared because it's coming off the posterior cerebral artery. Thalamoperforators, PCA, tip of the basilar. Does everyone get this? It's really, really good, and it puts you at a whole new level if you understand that concept. We're talking about ischemic vascular disease. We're getting to the nitty-gritty. But it puts imaging and your physical exam and your knowledge of anatomy all together. Pretty cool? Yeah? Where are you from? Pittsburgh. Oh, you told me that already. Sorry, didn't you? Oh, you're from Pittsburgh, sorry. Have you been to Minneo's?
I'm from the south of Pittsburgh.
All right. I'm not sure what that means. So we've talked about, that's the very, very, that's how subtle it can be. Cortical ribbon sign, I was playing with my graphics. Okay, by the way, this is different from the other patient I showed you earlier today. So there we are a few days later. That's a massive infarct. This is not, I don't think that's 24 hours. I think it's more than 24 hours. All right, more of the workout. Now, MRI, as we talked about, is more sensitive and specific. Diffusion-weighted imaging can pick up ischemia that's occurring within 30 minutes. So by the time the patient's at the hospital, we're going to see it. Limited accessibility, typically at stroke centers and university hospitals. In the old days, now, you can probably get an MRI at any of these community hospitals. I know Bryn Mawr, Lankenau, Paoli, Roxborough even has an MRI, I believe, with a tech in-house 24 hours a day, I'm pretty sure. And you can perform an MRA, which is that vascular study, magnetic resonance angiography, at the same time. Again, it doesn't require any contrast. Okay, another case. Way in the back. Who was doing the Eagles chant before? Okay, what's your name?
Matt.
Matt. Where are you from?
Philly.
Philly. Judge, you said, right? Yeah. Okay. Matt, what do you see here?
Looks like the first picture on the left side towards the bottom. It's evidence compared to
Very excellent. Great job. Great job. What's the most commonly missed finding on an X-ray or image? The second one. Radiologists are often sued because they make an amazing finding and then they miss this small developing tumor in the corner of the film. Because they get fixated on a finding. They think their job is done. What else do you see, Matt? I don't want you to go to court. What's the vascular territory here? PCA. What's the vascular territory here? What's that structure? What? Are you guys detecting a theme? What's that structure? Thalamus. Look at that. Flare. So it picked up something here, but non-specific, although given the patient's presentation, we were thinking ischemia. So this is flare. Again, picks up microvascular ischemic changes all over the place. This is chronic. But this, not really sure of age. Got the diffusion-weighted imaging. Bam, left PCA, mass effect, and left thalamic. That's acute to early subacute ischemia. You want to see that again? CT, flare on the left, and then diffusion-weighted images show light bulb bright areas of acute to early subacute ischemia. Without seeing it, what did the ADC map show in those areas of light bulb bright signal? Dark. That's exactly right. Oh, look what we have here. ADC map. Dark, bright. Look at the thalamus. Dark. This is a different level image, but that was bright. You actually saw it on the other one. Dark. Got it? There's a mismatch. Diffusion and ADC mismatch. Acute to early subacute ischemia. Got it? That's what I was explaining before. Now you've seen it, you shouldn't forget it. What does ADC stand for? No. Apparent. Diffusion. Coefficient. And what does DWI stand for? Diffusion. That's it. So DWI, diffusion weighted imaging, ADC maps, apparent diffusion coefficient maps. All right. We can do carotid ultrasound also. These are still done. They're really not done out of the ER anymore because we've got the cross-sectional imaging in terms of the CT and MRI so widely available. These are good for follow-up. It's also good screening tools when you listen to a patient's neck and you can hear little bruits or little whoosh, whoosh, suggesting an area of stenosis. In this patient, again, this is another FLAIR image. We just see all these spots and dots. I see these all the time. In fact, everything now is voice recognition, so when I dictate, my words kind of come up and then I just sign right there and then. Used to have transcriptionists typing up our reports when we're recording. I have a dozen reports that I can just hit a button and they populate a whole study. I have a macro. I have an automatic study for this. I see this more often than I see totally normal cases. This is normal. The ventricular system is normal. There's no shift in the midline mass effect. There are no extraaxial fluid collections. There are focal and diffuse areas of subcortical and periventricular white matter hyperintensity in both cerebral hemispheres. These are nonspecific and can be seen in a variety of clinical settings. If the patient is 50 or older, I'll say, and are most compatible with microvascular ischemic changes. If they're 40 and younger, I will say, while this may represent diffuse microvascular ischemic change, other etiologies such as collagen vascular disease, demyelinating disease, migraine, blah, 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 cannot be excluded. What happens between 40 and 50? It depends on my mood. Microvascular ischemic change can look like that, but I can use the same case and tell you the patient has MS. And you'd believe me, right? They kind of look alike. Okay, carotid ultrasound. We're going to get past this. Basically what it looks like, here's the vessel without any Doppler on it, but we can turn color Doppler on and it shows all the blood moving in this direction and it marks it as orange. So blood that is orange is moving in this direction. So we have the ICA and the ECA, common carotid artery right here. Internal jugular, which is bigger, and blood is flowing this way, and we assign a different color to it. So blue is blood flowing down this way, and orange is blood flowing that way. So we can do direction. We can also measure velocity. Here's an ulcerated plaque within the internal carotid artery. This should all be nice and wide like this. Should be a nice wide river. We see a mountain in the middle of the river with an ulceration in it. This is at risk for embolization. Here's another patient, a big, big plaque, nasty in the internal carotid artery, resulting in significant stenosis. We can put a little caliper on there. See how it's mixed colors in here? It's not blue and it's not red. It's almost like a yin-yang. There's blood flowing in multiple directions. That's turbulence. That's from stenosis. We can put a velocity on there. In this case, velocity is more than 450 centimeters per second. That's tight stenosis. All right. We can have MRA and we can have CTA. So MRA is what I showed you before. I also showed you a CTA. But while a patient is having an MRI, we can also look at their blood vessels. We use the inherent flow of blood as the contrast agent. We don't have to inject anything into that patient. So no contrast is needed. It can be done at the same time that the conventional MRI is being performed. You need little time to process it. The downside is you get artifacts. So if they've got dental work or if they're coughing or if they're pulsating, if there's a lot of pulsation artifact, it can give you a lot of false positives. And also for inpatients, if the patient is intubated, you really can't do a great study on these patients. On CTA, it does require contrast. Images are acquired very, very rapidly. You are not as susceptible to artifacts, but post-processing time is quite consuming. And I actually prefer CT. I think the images look better. My personal preference. By the way, a CTA is what I showed you with that aneurysm before. There we go. Common carotid artery, external carotid, internal carotid, a little bit of plaque right at the bifurcation. I showed you these images before. These are from a CTA. You can really, really get some very high resolution images from a CTA. This almost looks like angiography, like conventional angiography. The gold standard is still considered cerebral angiography. You put a catheter in the vessels, you inject it with a high volume at a high rate of contrast material. You can catch the arterial phase, the capillary phase, where it just looks like a little foggy, and then a venous phase. That's the advantage of the catheter cerebral angiography, and it's still considered the gold standard. There it is sagittally. This is from the front. This is from the side. Stenosis here. Really, really ratty. Hemorrhagic conditions. We see hemorrhage in the post-traumatic setting. You can also see subarachnoid hemorrhages that occur spontaneously. And you can have reasons for spontaneous intraaxial hemorrhages. Typically, you see it with anticoagulated patients or patients suffering from coagulopathy. Best of luck to you.
Thank you, sir.
Amyloid angiopathy. Amyloid results in large lobar hemorrhages. These patients are typically demented, not always, but they typically are. And they typically occur in patients of advanced ages. So if you have a demented patient in their 80s or 90s and you see a spontaneous intraaxial hematoma, think cerebral amyloid angiopathy, because a risk factor is dementia and increasing age. Okay? Vascular malformations, metastases, you can have hemorrhagic infarctions, and of course, hypertension, which typically begin at the basal ganglia, thalamus, or brainstem. If you see spontaneous hemorrhages in those three places, think about hypertensive hemorrhage. In terms of spontaneous subarachnoid hemorrhage, ruptured aneurysms by far are the most common cause. Patients do present with the worst headache of their life. Incidentally, if a CT is negative and they have the worst headache of their life, consider a lumbar puncture. If the lumbar puncture is positive, sometimes even if it's negative, angiography may still be recommended. If they've got papilledema and essentially an MRI is normal and you've done all the screening, you may be forced to order a cerebral angiogram. This is a typical appearing subarachnoid hemorrhage where there's blood meandering through the cortical sulci. There's also some thickening of the falx back here. This looks, I think I may have taken this from the case earlier. This is a post-trauma case. There's some extraaxial blood here as well. Multi-compartmental blood is what until proven otherwise? Trauma. Aha. Yikes. This was a young patient. This is one of my first pediatric angiograms in fellowship. Patient presented with blood-filled ventricles. This is all blood. The ventricles are, this patient's got hydrocephalus, probably from the volume of the blood, as well as clogging up of the arachnoid granulations. This is really, really bad. Patient was shunted. We did an angiogram. We see a part of a snowman-shaped abnormality filling up with contrast. And lo and behold, coming off of the posterior branch of the PCA, what do we see here? Anybody? Confidently. It's a bilobed aneurysm in a kid. Here it is on the CTA. This is on the right side. For some reason, sometimes they flip the images on the post-processing software. Bless you. Here it is here as well. Aneurysmal subarachnoid hemorrhage. You get the incidence is 10 to 28 per 100,000 in North America. Unfortunately, up to 50% die before ever reaching the hospital. 50% of the survivors have a major disability, and by the way, only a third will have a good outcome. So the bottom line is, if you have a risk for an aneurysm, if you have a family history, if you're on oral contraceptives, if you have a history of polycystic kidney disease or a family history of polycystic kidney disease, it may behoove you to have a discussion with your physician or for you to have a discussion with your patients about a screening MRA. Okay? Once you've had a subarachnoid hemorrhage or once your patient has had a subarachnoid hemorrhage, believe it or not, there's a 4% rebleed risk within the first day. That's not insignificant if you're in a busy center. 50% over 6 months, you have a re-rupture risk. 25% within the first 2 weeks. This is significant. These patients need to be treated appropriately, whether if it's clipping or coiling, they need to be treated. Incidentally, if you have a subarachnoid hemorrhage, you're at risk for a stroke. Anyone know why? Regional vasospasm. I've seen aneurysms at the junction of at the MCA trifurcation, right as it's going up through the Sylvian fissure, before it goes into the Sylvian fissure, which within 10 days, they get vasospasm. We've actually had to stent some patients' middle cerebral arteries due to vasospasm from a subarachnoid hemorrhage. We have so many tools in our toolbox now. The idea is for you guys to know what tools are in your toolbox, or what tools are in the toolbox of your consultants that you can help your patients. Risk factors. Females, they are familially clustered. We talked about these: hypertension, ischemic heart disease, autosomal dominant polycystic kidney disease, hypercholesterolemia, smoking, heavy drinking, and contraceptives. We can classify aneurysms. Typically, saccular and fusiform are the two main ones. It's an example of shapes of saccular aneurysms. The narrower the neck, this is a wide neck aneurysm, this is a narrow neck. The narrower the neck, the more likely they are to have a successful embolization. If we put coils into aneurysms, it's less likely that they're going to uncoil or escape, the narrower the neck. Here's some examples of actual aneurysms that we imaged in fellowship. Pretty darn big. The fusiform aneurysms, basically picture a hose and picture widening, sectional widening of the hose. Okay? You can't coil those. You cannot coil those. They require the work of a neurosurgeon. Aneurysm locations typically occur at junction points of major junction points within the circle of Willis. If you see one, you need to look for another. If you see one, you need to look for another. There's a major subarachnoid hemorrhage, and that's actually the path specimen. Ruptured basilar tip aneurysm. Blood throughout the basal cisterns, and this is what it looked like post-mortem. Massive subarachnoid hemorrhage. Massive subarachnoid hemorrhage. There's actually a blood CSF level in both lateral ventricles. Aneurysm therapy, medical-induced hypotension. Surgically, you can go in and put a clip across the base of it, or we can put a little catheter up and deliver little coils in there to clog it up. Advantages from surgery: it's immediate protection from rupture. You have the aneurysm here, and here's the parent vessel. You put a clip right across the bottom of it, and they're basically cured for life from that aneurysm re-rupturing. Disadvantages: it's more invasive. It requires general anesthesia. A surgical exposure can be very difficult, and I used to have a movie in here. There's a clip being put, here's the vessel here, going across, here branches of the vessel, and here was a big saccular aneurysm here. They put a clip right across the base of the aneurysm, and they left it in that way. That's what surgical clipping looks like. And I used to have a movie that actually showed what it looks like to actually put a clip across an aneurysm. It's really fascinating. Yeah, that was it. So when coiling aneurysms, you deliver a wire-shaped device that goes inside of the aneurysm, and you deliver this coil until the entire aneurysm is isolated from the blood supply. And then that patient is presumably protected for years and years and years and years. Okay? The aneurysm won't rupture again. It won't continue to get large. That's endovascularly. And that's what it looks like. Nope, it didn't take my film either. It didn't take any of the animations, I guess. This is what a coil mass looks like after an aneurysm has been coiled. See how all the vessels are filling up with contrast? The aneurysm is not filling up with contrast. And this is what's called a coil mass, and that's what we want to see. This is what we want to see immediately post-procedure, showing that there's no contrast going in there anymore. It's totally isolated. This is a video of my 3D angiogram. Nope, didn't come. I apologize. This is what embolization actually looks like during the procedure, feeding the wire up. And ultimately, we keep packing it and packing it. This was at a basilar tip aneurysm. And here is the angiogram to make sure that it's not filling anymore. And as you can see, it's not filling with contrast. So aneurysm therapy, it's effective in preventing rupture. Endovascular aneurysm therapy is lower morbidity and mortality than surgery. Surgery does have its advantage for that wide neck. Again, if you have a wide neck, that coil mass can uncoil. Presently, the recurrent is main limitation of endovascular approach. What that means is the endovascular approach, you tend to have a higher recurrence. But the trauma that's required to fix these things endovascularly is so far less than going in through the skull. Cerebral amyloid angiopathy, we talked about this. The risk factor is aging. It's deposition of amyloid in the media and adventitia of small to medium vessels. You will see this in your career. So a demented, aging patient, massive hemorrhage, think cerebral amyloid angiopathy. And there's a case of it. What kind of stain was this? What dye does it stain? Congo red. Congo red. Is that a board's question? Yeah. Oh, yeah. Yep, even I remember that. Hypertensive hemorrhage, you have a thalamic hemorrhage. That's a hypertensive hemorrhage until proven otherwise. Hypertensive hemorrhage, which took origin in the basal ganglia. I can't tell exactly where, but obviously the basal ganglia is affected here. Hypertensive hemorrhage. Okay, let's bring it all together. CT is an excellent screening tool. MRI is more sensitive and specific for ischemia. CTA and MRI are both excellent non-invasive means of vascular integrity. Catheter angiography remains the gold standard for imaging the cerebral vasculature. For aneurysm, hypertension, and cerebral amyloid angiopathy, think of those as causes for spontaneous intracranial hemorrhage. That's it. Thank you very much. Right on time. Any questions? Is that a lot to digest? It brings a lot together, right? Anatomy, physiology, pathology, it all. Hi.
Yeah.